Whilst the dentist or even the hygienist are the ones that may deliver the care, high quality research in a primary care setting depends upon the whole practice team.
Welcome to the Dental Protection Podcast. My name is Terry Simpson and this is the Research in Dentistry series. This is the second in the series, and in today's podcast we talk about getting research into general dental practice. I'm very happy to introduce my two guests, Professor Jan Clarkson, who's Professor of Clinical Effectiveness at Dundee University, and Dr. Josh Twigg, who's an academic lecturer at Leeds University. Jan and Josh contributed to our first podcast in the series, and I am very grateful to them joining us today. So welcome to you both. Josh, I'll come to you first to discuss why research is sometimes seen as less relevant to general dental practitioners. Well, much research is sometimes seen as less relevant to general dental practitioners.
Yeah, thanks, Terry. So I think there's a few kind of barriers to research being taken up and implemented in general practice in some ways. The first is that often academics don't do the best job of communicating their findings and its implications to the wider public and practitioners. So academic writing is often kind of couched in this needlessly complicated language, and of course the publishing process, unless you're publishing your articles open access so that they're free at the point of access, they're often hidden behind a paywall for the journals. Now, there's been more recent changes which have definitely improved that, particularly engaging with patients and the public in designing research and disseminating the findings. But it's still an area to work on. The other thing is that traditionally well-known research has been what we call efficacy research, which essentially proves that a novel intervention works under ideal settings. But this doesn't translate well to general practice, where your population may be very different from your strictly selected research population, and the level of control over delivering an intervention might not be kind of realistic for a real world setting. And then the final kind of probably biggest barrier is just time. So dentists are busy, and they have to balance enhancing their clinical skills and working on communication and aspects of business management, professional development and planning. And really that leaves them very little time to read through what is a huge volume of research that's published in any given area.
Okay, so do you think sometimes it's difficult also to produce those results in a busy practice setting, really, the results that are produced maybe in an academic?
Yeah, so we talked in the last episode about the fact that the majority of research is done in a secondary care setting or with a closer link to an academic unit. And we talked about external validity, so being able to apply the findings of a study to your population or to a wider population. And that's certainly a big barrier.
Okay. Jan, sometimes I'm going to be a bit controversial here and say sometimes that we hear about academics are in ivory towers in many ways about the kind of research they do. Do you think that's a fair criticism or not?
I suppose, it is an ivory tower compared to general practice, in that time can be unlimited for research. I think time is not a factor. So in terms of that external validity and to be able to replicate, particularly, I suppose, maybe that comes within the NHS setting, is something to consider. I think also the other thing is that often, in terms of clinical research, it's actually sort of like people who are experienced or specialists that are providing that treatment. And I suppose we've got an example of two of the trials that are funded by the NHS that we're undertaking at the moment around selective caries removal compared to conventional caries removal. And we're now undertaking the largest trial in the world to actually address that question. How can that be translated into a general practice or primary care setting? What is required in order to replicate results, as well as generate the highest quality evidence? And particularly the trial that's looking at pulpotomy in a permanent molar compared to root canal treatment. And that has a prospect of changing practice around the world. And pulpotomy in permanent molars is something that really has only been established in that ivory tower setting. So we are looking at how that can be translated into where the majority of care is provided, and can those findings be replicated?
Right.
But sometimes, the two work hand in hand as well. You do need maybe novel techniques or interventions to be developed, but it has to then be translated and cascaded down into
Mm.
where the bulk of care is provided.
Yeah, I mean, I guess the results have to match GDP perceptions, otherwise there's a danger to be ignored, Josh. What do you think about that?
Yeah, so not so much the results, but the design of the study and the way in which an intervention is conducted has to be something that's relevant and applicable to general practice. Otherwise, you end up with practitioners just disengaging with the research because it's so far removed from what's realistic for them to deliver that you can easily get that kind of ivory tower perception and just think, well, this is pointless and is never going to apply to me, and just stop engaging with it, and that's a real danger.
Mm. And what about we've talked a lot about dentists, but are there other dental healthcare professionals that have got an opportunity to participate in research as well in practice? Jan, are you aware of any projects that are running at the moment with dental care professionals? I know certainly hygienists have been quite prominent in one or two areas of periodontal research, haven't they? I think.
That's right. That's right. I mean, I think it's very much sort of like hygiene therapists have been more involved than other groups, but increasingly, I suppose, extended duty nurses. When you come to prevention,
Mm,
actually, the delivery of intervention often includes other members of the team. And in terms of involvement in research, if you are going to deliver research in a primary care setting, to be frank, it's the other members of the staff than the dentist who
mm,
make it happen. And that can include the receptionist. It is
mm.
the dental nurse. Whilst the dentist or even the hygienist are the ones that may deliver the care, high quality research in a primary care setting depends upon the whole practice team.
And dental protection very focused on dental healthcare professionals nowadays. It's one of the expanding areas of our membership, and I think it's very important that we cater for them and we're able to explain to them the opportunities that are there for them in research that's ongoing. Is there anything different about participants that we might see in general practice from perhaps an academic setting for the basis of research, Josh?
Yes, so often these are people who sort of self-select as having an interest in research in the first place, and probably a more vested interest in their own kind of health and care.
Is that people that are in a hospital setting, you're saying?
That's
Yeah,
right.
yeah,
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 yeah.
yeah.
Obviously, with increasing integration of research in primary care, then that difference in population will start to shift, and we'll see a more representative patient population in research. But there's still a tendency towards a population where they're more accepting of an intervention that may not be accepted in general practice, and they're willing to sit around for 2 or 3 hours each study visit for all the extra bits of work you need to do on them. So they're clearly different from your general practice population.
Okay, thanks, Josh. One of the criticisms we sometimes hear is that there's a lack of money in social healthcare settings to achieve good results. Is there any basis for this? Jan, have you any thoughts on that?
I don't know. I mean, I think that's a very complicated question, actually.
Mm,
But just going back to Josh's other point, in all of the research that we've conducted in a primary care setting, the recruitment of patients is phenomenally high. And actually, about 80% of those patients eligible agree to take part. And in terms of conducting research within that primary care setting, the whole question of funding that is required to deliver it is complicated. If we go to the COVID times, what is really exciting is how research was efficiently, effectively, and timely done. And that was about everybody working together. And actually, that could be realised within a dental care setting if the principles of research were embedded within the system. Things can be effective. So, and I think Josh is going to talk about adaptive trial designs, which really came to the fore during COVID. If we all work together, that would be such an efficient way of embedding research actually within the healthcare system. Now, in terms of monies available for high quality research, there are monies available. I mean, one of the challenges is, I suppose, persuading funders that actually not only is the research that you're going to conduct important, relevant, but also that you've got a team around you that can deliver it. And that is why a lot of grant applications fail, actually. It's not that there isn't the money necessarily there, but actually they're not persuading funders that they have the skilled team around to deliver the research. I do think there are opportunities going forward. And sort of like, I think this is a wonderful opportunity too, to sort of like MPS's role to actually embed research within systems, because that is where efficiencies and the cost of research can be realised.
Thanks, Jan. And Josh, I think when I've spoken to you before, you've felt that maybe if there are financial restrictions, that funders are really interested in specific types of research more. And I think and I think there are examples out there. I think you mentioned preventive, very much preventively oriented.
Yes. So the attraction of research into disease prevention is, in the longer term, you're likely to generate a cost saving because you're avoiding the need for further treatment and, all the negative aspects of whatever disease you're trying to prevent. And obviously, Jan's done lots of work on disease prevention up in Scotland, and I think was involved in Child Smile up there. So caries prevention in young children. In Leeds, we've got a similar project that's really trying to integrate that attitude to prevention in the community, called Raised in Yorkshire. So that's led by Professor Sue Pavitt, and is looking at actually peer-to-peer mentoring. So sixth form school children giving oral hygiene advice and toothbrushing, supervised toothbrushing sessions to younger children within their community, so that it becomes a kind of self-perpetuating intervention.
Great. Well, thanks very much for that, Josh. Jan, do you have any examples of good collaboration in general practice to deliver quality research? And some of your experiences and barriers you may have encountered in trying to get some of that research into practice?
I think sort of like the trials that we've undertaken, these large-scale multi-centre trials across the UK, I don't think there's a barrier in terms of practices taking part. We are amazed by the number of practices who want to engage in the research, and it is establishing that practically it can be delivered within that setting. With funders and with any research, the real challenges are recruitment. And for us, I suppose it is that recruitment of practices, but also then the recruitment of patients. And often we find that practices and dentists will maybe overestimate the number of patients that they see that would be eligible for trials. So it can then have the impact of increasing the length of time. But in general, we work with some incredible practices who are so enthusiastic, so effective at actually providing and delivering the research, and also patients who willingly are interested and want to increase the evidence to support the emergence of new care and evidence-based care, not only for themselves but for others.
Right, thanks very much, Jan. Josh, you've worked in general practice for a few years. Can you think of any types of questions you personally would like to see answered in basing research in a GP setting?
Yeah, so I think, if you look at where the shortfalls of most traditional trial designs are, it's in the kind of really long-term, almost life course follow-up of intervention. So if I do a filling using this new technique, what is the likelihood it will succeed at 10 years, 20 years, 40 years down the line? And often that's a question that's really difficult to answer with a trial, largely because of costs and the ability to follow people up over those periods of time. So that's where more observational longitudinal research can be really useful and maybe be more appropriate design. And then the other thing that Jan mentioned earlier is this idea of an adaptive trial. So this is where you can keep a trial running, but add in new techniques or interventions that match the kind of development of new clinical innovations as they arise, so that what you're looking at remains relevant to current practice, and equally you can remove interventions that you find are less effective as the evidence emerges.
Okay, well, thanks very much. Jan, you mentioned randomized trials. Are there many of those going on currently in practice, and any one that stands out in your sort of mind as being particularly of relevance and that dentists should look out for?
So yes, so there are quite a few NIHR funded trials ongoing across the UK at the moment.
Could you just tell us what IHR is?
Yeah, so that's the National Institute of Healthcare Research.
Right.
And it works across the UK. And there are two types of studies that they fund. What they're called is a commissioned call. And that is where the question has been identified to be a priority for the NHS.
Mm-hmm.
And then they do a researcher-led funding where someone puts in an idea themselves. The main trials that are ongoing at the moment are all commissioned trials. And we're leading two around caries treatment. That is the selective caries removal and the pulpotomy. Zoe Marshman in Sheffield is leading one around behaviour change for anxious children in general practice. Richard Holliday is leading one again across the UK around smoking cessation and impact on periodontal health. And there are others that are beginning to start. So we have secured many millions of funding to do dental research that are ongoing. And also, Josh mentioned Sue Pavitt. Sue, who is based in Leeds, she chairs what is called the Oral and Dental Specialty Group. So NIHR as well funds to support research around the UK, and there are actually 14 different areas. And I represent Scotland on the group, so we meet regularly. And what they have appointed are primary care champions as well. So I think, Terry, if anyone is interested in being involved and wanting to find out more, that would be a route in.
Josh, very quickly, could you just tell us a little bit about the role of qualitative studies in practice, perhaps?
Yes, and we've touched on this in the previous episode, but essentially your trials and your quantitative approaches to research can give you the what of your research question. So what treatment works, or what's the risk of X. Whereas your qualitative studies start to address the reason why that might be the case, or particularly when you're looking at things like behaviour change or access to care, you can start to identify the things that really act as barriers to for instance, accessing care, or what would encourage people of different communities and backgrounds to engage with care more, or is viewed as prohibiting them from accessing care in that way. So it's the other side of the coin to working out the most effective way to deliver an intervention, finding out people's attitude to that, and whether it's actually going to be acceptable to them and whether it's feasible for them to engage with.
Great. Well, thanks very much, Josh. I think just quickly to sum up now, the last question, I'd put this to Jan, is really how do we enthuse practitioners and other dental healthcare professionals to get involved in research?
I mean, I think it's almost starting early, and I think sort of like it's the role of undergraduate training really to just communicate how important and vital and exciting it is. I think within vocational training, that is an ideal setting to give experience, and certainly that's what we've tried to do in Scotland. And I think it's also remembering that there's a huge amount of research that is conducted that is a waste of time and energy. And it is realizing I suppose, the value and the excitement and worth, that if you're going to be involved in research, that it is of the highest quality and with the best team around you. And that it is that those results have got the potential of being translated into clinical practice that will make a difference to not only patient safety, but also to results that affect the health and well-being of the dental profession as well.
Thanks, Jan. Josh, just finally, establishing links with academic institutions, is that something that a dentist and healthcare professionals in practice should look to do? Is that a good place to go if you were thinking of conducting your own research?
So certainly, as Dan's pointed out, you need to establish a team around you, and academic institutions are the best resource for practitioners who want to engage with research to achieve that. So I think working through the primary care research champions is a great way to access that resource and really start to develop active engagement with research and bring that team around you to support the delivery of research.
Well, thank you so much to both my guests today for their very informative contributions. And with that, we reach the end of today's podcast. If you'd like a certificate for listening to go towards your CPD, or to learn more about what we've covered today and who you were listening to, please do take a look at the podcast description. I've been your host, Terry Simpson. Thank you for listening.